So thank you for being with us. Is kind words from Margaret. So thank you very much, Margaret, for the kind introduction. The way that I am able to bring information to you is because I try to stay very plugged in. I just came from Indiana, did this presentation in Indiana. I'm on my way next week to Washington, D.C. on behalf of NARHC. Get my slides going here. There we go. Some of you may or may not know me. I'm the past president of NARHC, current president of Illinois Rural Health Association, done a lot of lobbying on behalf of us as rural health clinics. And we have a lot of pertinent issues facing us right now, really basic ones. I'm not going to go down those right here today. I will talk about current billing issues and a lot of the changes that still are confusing folks because we've got some phased implementations happening, shall we say. So let's dig in. Many of you may be tiring of some of these topics. Telehealth status. We're going to talk about what happens with telehealth at the end of the public health emergency. We have a lot of changes with behavioral health that really are the main focus of what I want to cover today. I have these mixed around a little bit. GT025 utilization should actually be up in the telehealth summary. We're going to talk a little bit about care management, but more so in care management about some of the other services that are available via care management. And again, a little bit out of order, I'm going to talk about some of our new behavioral health providers and that status. Unless you've been under a rock, which some of you may have, gladly so, perhaps. We know that the public health emergency ended on May 11. The biggest question with the PHE termination really revolved around telehealth. So we know that on the PHE, May 11, it's over. We're well past that now, so that can't be new information to anyone. Going back to conferences, I went to a Taylor Swift tribute thing with my wife and my daughter the other day, and we're all gathered in this tight little space. And I thought, wow, it just doesn't seem, it's not that long ago that we could not have done this. And we're trying to figure out what we're going to do during the public health emergency. So it's a little jarring that it's over. 3 long years that went by very quickly. And I know many of us lost a lot of people. And so we can't forget about that. As we go back to some kind of new normal, telehealth services were affected by the flexibilities we were issued, phased in during the beginning of the pandemic, and there were effects on providers, hospitals, long-term care facilities, and of course, rural health clinics. We had a bunch of flexibilities. Some of these flexibilities were made permanent. It's a big item we're going to talk about with the behavioral health issues. Telehealth is in a bit of a limbo. We had supervisory requirements that were waived that have not been made permanent, and we've had temporary expansions we were able to do that has not been made permanent. Some of our flexibilities have been made permanent, others have not. It's part of what I want to sort through, particularly with telehealth and billing. So the big question, PHE, what's going to happen to GT025 at the end of the pandemic, of the public health emergency? Everybody has the feeling that the genie is out of the bottle, but for clinical visits, are we really utilizing telehealth that much for just clinical visits anymore? Behavioral health, yes, I think behavioral health is the norm. So I think our utilization of telehealth for clinical visits has leveled off, if not tapered down to a bare minimum. And regardless, our GT025 that we use for those, that has been extended through 12/31 of 24. Extended through 12/31 of 24. We will still use GT025 if we have a telehealth visit for our rural health clinic or rural health clinic patient
I remember I told you I have a webinar and I hope I
And
better that 4 pounds was gained from that. I just dropped like 8.
I was talking about telehealth being made permanent. Telehealth has not been made permanent through 12/31 of 24. G2025 is applicable, and telephone only visits are included. So telephone only visits via telehealth, G2025, we have the capabilities to do regardless of originating or distant site through 12/31/2024. I can tell you on behalf of RHA, I was fortunate enough to attend the Policy Institute in February, which I really love to do because I do love to go to DC for advocacy. I get a big kick out of it because I get to talk to fancy people for one thing, and really I just like to go look at fancy airplanes at the Smithsonian, but don't tell anyone. So I was fortunate enough to meet with Senator Durbin on our Illinois delegation, and as part of our Illinois delegation, and his first question about extending telehealth is, okay, well, how about somebody in Chicago just cranking out rural health clinic visits? And obviously if they're in Chicago, they're in a non-rural area. How do you eliminate fraud? And I kind of tiptoed around the answer, and my answer, frankly, is who cares? That's the point of telehealth, is to improve access to care. But going with the exercise, that's the big concern on the part of policymakers, is the seeming latitude for fraud, opportunity for fraud with telehealth visits, though I still don't, it's not fraud to me. And what are we going to do with telephone only visits? So instead of making a permanent solution, we've kicked it down the road through 12/31 of 24, the status quo will apply. G2025 is a composite or an aggregate code. It's not paid at the encounter rate. This removes any telehealth services from your cost report. And since it's an aggregate code, the reason we use that term is because it represents an aggregate reimbursement amount of all 290 services available to providers utilizing telehealth. Is the national average of all max for all 290 of those services. And we come out to 98.25 for 2023. Now, here's a question, and I only ask trick questions. So what is not on this claim? A couple different things. First, there's no CG modifier. We're no longer required to put a CG modifier on a telehealth claim. That went away 18 months, 2 years ago, right after actually the initiation of G2025. The other thing is there's no detail on here. So posting detail and tracking services that are rendered when you're doing a telehealth visit is complicated because we cannot submit the actual service detail with our telehealth visit like we would on a normal claim, which brings up annual wellness visits. During a telehealth visit, you could submit the annual wellness visit, but Medicare is not going to know it was an annual wellness visit, and you're not going to know it was an annual wellness visit unless you include detail on the claim somehow and suppress that from going out with the G2025. Telehealth claims for Medicare will only pay with G2025 on the claim. Telephone only visits count, and for both telehealth, it can't result in an encounter, and it can't have it cannot have resulted from an encounter within the past 7 days, and it can't result in an encounter in the next 24 hours. 7 days look behind can't have resulted from an encounter, and 24 hours in the future, and it has to be at least 5 minutes of what would otherwise be face-to-face time with a provider or physician who's reporting a level of evaluation and management service. So it's not just picking up the phone and saying, hey, or whatever. It's got to be at least 5 minutes. It can't result in an encounter, and we don't get paid the rate for that, which here is the impact. Another big issue is policymakers and legislators do not want to pay rural health clinics the encounter for one of the reasons I just said, as paraphrased from Senator Durbin. But also, there's just a big question if a telehealth encounter is worth the same cost as a rural health clinic encounter. And so far, the policymakers' response has been no. And since this is an aggregate code, we remove the cost for those services out of our cost report. That's why we can bill something that's not an encounter payment separately on the UB04 because it's not included in our cost report. And here's the thing, if those become encounters, a lot of people are going to have trouble keeping their rate if all of a sudden the telehealth visits they are doing are counted as encounters in the denominator of their cost report. It's the basic cost per patient. If you have fewer patients in the denominator, you have fewer patients over which to spread the same cost. So there's a big cost reporting implication if we get in telehealth visits as encounters. And right now, the point of this slide is those costs are removed from the cost report and they don't get counted in our productivity. G-code payment rates, you cannot find in a fee schedule. If you go look at your NGS or WPS fee schedule, you're not going to find a code for G2025. You've got to go to the CMS Rural Health Clinic Center. Just Google exactly that, CMS Rural Health Clinic Center, and you'll come up to the CMS site where they publish this material annually. I think it comes out in MLN too, but that's the easiest place to go find it. We'll see right there in the middle our telehealth visits for 2023 at 98.25. We're going to talk about care management and coordination of care management. We see those are 77.94, 147. I have a tendency to mix around what I read on the slide, I guess, just to see if everyone's paying attention, or really to try not to read slides in the first place. And we see at the bottom our virtual care communication. And I've removed this slide. I talk about it a little further. We do have some services that are no longer included in GG0071. We're going to talk about virtual care communication towards the end of the presentation. A forgotten flexibility of the PHE is that not CMS, but the Office of Inspector General, HHS OIG, stopped enforcing any kickback provisions if coinsurance was waived by providers. Remember, at the very beginning of the pandemic, in a public health emergency, everyone was waiving coinsurance just to get patients to somehow come in and unstick the machinery, so to speak. So, of course, with the end of the public health emergency, our ability to waive coinsurance, as was enacted because of that, the feds let us, okay, everybody, you can not charge your patient of commercial Medicare or Medicaid, waive coinsurance at your own discretion. We will not enforce any kickback provisions during the public health emergency. That is, of course, gone. I don't think people were using that a lot, but I just like to state it for the record. No more arbitrary waiving of coinsurance after the end of the PHE. These are some of the items that have been made permanent. The flexibilities that we've received during the public health emergency that not only didn't go away with the end of the public health emergency, but which we received legislative changes and updates to make some of these flexibilities permanent. And actually, some of them don't really have anything to do with that. But really, if we talk about allowing telehealth, that's the big change. We have an encounter definition change. It's the first time I've seen a change in the definition of an encounter. All of us know fairly well, I think, the conditions for certification, conditions for compliance. 419, CFR 419 gives us all of our staffing requirements, our hours that we have to post, who's a provider, who's not, locations, etc. Another relatively unknown reg is this right here. It's CFR 405. This gives us all of our various definitions how payments are legally made to rural health clinics for rural health services and non-rural health services. What is a visit? You see that links are coming up as I hover. How we get paid, our payment rate. All these are in a little different section of guidance. The CFR 405 defines our allowable costs. Look at that, FQHC supplemental payments. It's one thing I'll be talking in DC about next week. Medicare Advantage. We need supplemental payments, just like FQHCs get for Medicare Advantage payments. Different question. What I want to talk about here is what constitutes a visit. The definition of what constitutes a visit was legally changed. So we got this in a reg update. I'm trying to think, was this part of a bill that passed Congress? I don't think this particular part was. I think it was. Forget it. It doesn't matter. The important part is now a rural health clinic visit includes a mental health visit rendered face-to-face or via real-time audio video telecommunications technology, i.e. telehealth. So let me repeat that. Our RHC visit includes mental health visits. Mental health visits and mental health visits alone now include face-to-face encounters or telehealth visits. So everything I just talked about with the G2025 does not apply now to a behavioral health visit because our behavioral health visits via telehealth are now encounters. So this allows us to have an LCSW on the clock, on their clock. Doesn't necessarily have to be during RHC hours, but the LCSW is at home and the patient is at the clinic or the patient is at home. LCSW is on the RHC cost report for right now, this moment in time. And that LCSW can conduct a telehealth visit at what would otherwise be a distant site. So for behavioral health, as long as our approved provider is on the rural health clinic cost report, those costs are included in our cost report right now. You did notice that I said it doesn't necessarily have to be during clinic hours. I know I'm raising questions and I'm going to create myself a lot of email, so be gentle on me. But the test is not that LCSW is necessarily providing that telehealth service via clinic hours. The test is that LCSW on the rural health clinic clock? Yes. And that claim is going to go as a rural health clinic visit. And it's going to be paid at the AIR. That's brand new. This includes audio only visits. So an audio only behavioral health visit via LCSW or clinical psychologist for that matter, or advanced practice nurse with a psychiatric specialty, depending on the service that person is providing, telephone only, 0900 revenue code would be a telehealth visit, an encounter, would be an encounter. Initially, I know why I was getting confused, because this was introduced in 21, still during the public health emergency. And there we go. The Consolidated Appropriations Act of 2023 delayed what was an original in-person visit requirement for these behavioral health telehealth visits. So the way this originally came out, LCSW can do a telehealth visit. It's going to be paid as an encounter. Forget GT025, but there has to be an in-person visit every so often. The in-person visit provision is also waived until January 1, 2025. So for right now, telephone only, audio-visual telehealth encounters via behavioral health provider will be paid as an RHC encounter at the AIR. Now what we have to do is change our revenue code, of course, and we do have a different modifier. So that advanced practice, here's the difference. That advanced practice nurse. How about psychiatric nurse practitioner? If that person is providing counseling services and it's a med rec only, I'm providing no primary care, and they're doing counseling, I don't know, do advanced psychiatric, advanced practice nurses do counseling? I know they would do med recs. It's a question, it's out of my skill level. That person would bill an 0900. LCSW would bill 0900. Behavioral Health Revenue Code, along with the CG modifier, and we're going to use modifier 95 for a pure telehealth visit with audio visual, and an FQ modifier for audio only. FQ modifier for audio only. Be careful how you say it. That's how the claims would look. CG modifier 0900 revenue code, going to be paid at the encounter. This is adding confusion to the fact that not only for the one time I've seen during my professional career where we've had an encounter change, our encounter definition changed to include that behavioral health visit for telehealth. Now we've expanded approved RHC providers. We've done it in a couple different phases, which is creating confusion. Phase one of this change is that in 2023 CMS final rule, we'll send these slides out, send these to Margaret, she'll send them out. Here's the final rule. Behavioral health services via LPCs, licensed family therapists, and behavioral health counselors. So LPCs, LMFTs, whether those specifically mentioned, are allowed under general supervision of a physician or non-physician provider, i.e. LCSW. Let me repeat that. We can now have 2023, right now, our LCSW can bill for services rendered under general supervision by an LPC. LPCs, licensed marriage family therapists, CPCs have not been recognized by Medicare, and they could not be rendered under general supervision. Previously, now they can. 2023 CMS final rule, under general supervision, we get these providers. But we also had the Consolidated Appropriations Act of 2023, which expanded our rural health clinic provider definition to include marriage family therapist services, and somewhere else in here, and others, that's marriage family therapist. So and mental health counselor, there we are right at the top, mental health counselor. So that pulls in our LPCs, CPCs, whatever we were calling them in our particular state. So 2023 CMS final rule, general supervision. Consolidated Appropriations Act comes along. This is the law that passed. It's the difference. It's the law that passed Congress, wrote into law that these new behavioral health providers are now recognized by Medicare. They're recognized by all of Medicare. We won't get a rule for them until 2024. So right now in 2023, we have, you see down in the lower right, general supervision, our new providers. Next year in 2024, the law passed this year, but we won't have rules until next year that these are approved providers. So these providers will be able to bill a claim on their own. We don't have to have supervision, don't have to have anything else. They can bill out of the rural health clinic. And that starts next year. We have to have rules in place such as, okay, what if the LPC is the only one there? Can the rural health clinic be open? We don't know. What about, any number of questions, think of them. That's why we have to wait until 2024, because we have to get these compliance issues resolved. General supervision right now Approved providers, 2024. Stay tuned for rules. Big change, big deal. Largest expansion of behavioral health providers. Boy, since I've been doing this for 30 years, and I think Medicare said largest expansion of behavioral health providers ever. So it's a big deal. We had some, not changes, but we had some changes to our care management services provisions. I don't want to dwell in detail on these because we can go down rabbit holes on care management and service requirements and all those things. I really want to hit on the high points. The two I really want to highlight, or like three, pardon me, are our principal care management, our psychiatric collaborative care model, our virtual care management, and then jumping back up to general behavioral health integration to highlight the fact that so many of our patients are eligible for behavioral health integration that the bar is very low for getting them included in care management services. I want to talk a little bit about that. 2023 G0511 general care management services. This is for any of our Medicare patients that have 2 or more chronic conditions, which are going to lead to their potential decline, decompensation, illness, or death. 2 or more chronic conditions. We all know that that's a healthy patient for many of us. Current payment rate is $77.94. G0511, look at that. 3 national non-facility PFS payment rates, physician fee schedule payment rates, of those 3 CPT codes that were mentioned. So it's the same reimbursement setting function. It's an aggregate code as we have in our G2025. And the G0511 is the aggregate of those 3 codes, which gets us $77.94. So your Medicare Advantage plans, for example, I often get the questions of, will our Medicare Advantage plans pay our care management service fees? And the answer is no, they won't pay a G0511. A Medicare Advantage plan that is paying you as a rural health clinic will pay the G0511. But a Medicare Advantage plan that requires you to submit on a 1500 is probably only going to recognize the straight CPT codes there, the 99490. So if you're submitting on a 1500, the G0511 to non-Medicare payers will not be recognized. There's a Medicare rural health clinic specific code that only we can submit anywhere. So don't try to submit that to commercial payers, they won't recognize it. We know the billing requirements. Excuse me, maybe we don't. 20 minutes of care coordination services in a calendar month. It's not the month that makes the service billable. It's when you have 20 minutes of activity. And this is where we can get squishy. What is activity? Care coordination services are activities by really clinical personnel coordinating referrals, coordinating with community services, following up the patient via telephone, scheduling appointments and administrative functions. Oh, hey, patient, I need your updated insurance card. It is not care management services. Oh, Ms. Jones, first of all, I'm checking in to see how you're doing. How are your new meds doing? We need to make sure you got in to see your cardiologist. I'm trying to schedule that appointment. When are you available? Those are care management services. The first ones were not. 20 minutes of those, that's what makes the G0511 billable. Option A is our 2 or more chronic conditions. Look at option B, back on our behavioral health thread. Any behavioral health or psychiatric condition being treated by the RHC or FQHC practitioner, not the behavioral health provider, any psychiatric condition being treated by the RHC nurse practitioner, family practice doc, and including substance abuse disorders. We all know how desperately our patients need these services and how chronic our substance abuse issues are. And option B opens up G0511 to those types of interventions. So we have a second option that I think is rarely utilized for G0511. We have to have an initial assessment with validated rating scales. I'm thinking of the, what is it? The 20 questions to determine alcohol abuse. Those types of rating scales, depression screenings, behavioral healthcare planning. We have to recognize patients who are not progressing and whose treatment plan needs to change, et cetera. But G0511, I think, is a powerful option for us to start integrating and increasing the level of service that we're providing in our rural health clinics. We also have psychiatric coordination care, which I always think bears reminders that we have this here. People are afraid of it. It's complicated. I get it. It's a higher level of service. We have to have a behavioral health team in place. And that means maybe we have an LCSW seeing patients in the clinic, and the only other quote unquote supervisor there is a family practice doc. So, we have to have somebody behavioral health wise managing that from the outside and advising the family care doc, advising that healthcare team on their psychiatric program. We can go down the rabbit hole of that behavioral healthcare team. I just was speaking with somebody at the conference just 2 days ago in French Lick, and that's what scares them. They don't quite understand how to implement that behavioral health team. But this is an option that's available to us. It's 70 minutes the first month, 60 minutes in subsequent months of psychiatric treatment and counseling for patients. And we have a payment of $146 for this. So again, is G0512. It's a rural health clinic only code. More common, perhaps more commonly used. I don't know if it's more commonly used. I don't know a ton of people that are doing principal care management. But it's a more recent benefit that I think also gets equally overlooked is our principal care management, which is effectively care management for one condition. The threshold has changed. It's expected to last at least 3 months. So if a patient has one chronic condition that is, remember on our G0511, initial qualification was 12 months or more. Principal care management is 3 months. And the same service requirements. I'm not going to read them all to you. I'd like to talk about virtual communication services. Virtual communication services went largely ignored during the public health emergency. Were largely ignored. The reason they were ignored is because we have G2025 now. So we have a way to bill a telehealth visit. Remember at the beginning of the public health emergency, when we didn't know what we were going to be able to do with telehealth, we were being told, well, just bill it as a virtual communication service, but we know it's only a $23 payment. Now, virtual communication services are meant to be really digital check-ins, a way to check in with your provider and offer a way to evaluate that patient remotely. Part of the thinking was, and this came out before the public health emergency, okay, our providers who were doing some of these communications via email or even text can check in with my provider. And as long as it doesn't generate an RHC encounter, we haven't had an RHC encounter. I always have trouble saying this. We haven't had an RHC encounter in the last 7 days, and does not lead to, it's the same telehealth requirement, doesn't lead to an RHC visit in the next 24 hours, we can bill a virtual communication service. This is where I have a hard time distinguishing what's what. G2010 and G2012. One is a remote check-in, and the other is a remote evaluation. Are those codes that are now included? This is another aggregate code. These are the codes that are now included in G0071. A digital evaluation is specifically what 99421 through 99423 are digital evaluations. Honestly, I'm not quite sure what that means. What I do know is those were added to our aggregate code calculation for G0071 during the public health emergency, but now they no longer are. So our digital evaluation services are no longer included in virtual communication service. I think you know what these are, now that I'm thinking about it. These are portal visits. Patient comes in and you're trying to do evaluation and management somehow during the portal. I think as rural health clinics, that's not going to be something that we're utilizing. We have enough trouble getting patient forms over the portal, much less trying to do a digital evaluation over the portal. My point is, I've had a lot of questions and confusion about these 9942X codes. Those are no longer included. So if you do that digital evaluation, you can't bill it as a G0071. It is the same with remote patient monitoring. Remote patient monitoring is not included as a virtual communication service. It is not part of what we can do as a virtual communication service. It's not a G2010. It's not a G2012. That's how we know on what these aggregate codes are. That's how we know what we can perform. What CPT codes were included in this aggregate code? Remember, we saw the three care management codes for the general care management G0511. So that tells us, okay, those are the services that are included in the G0511. Long-winded point now, digital evaluation no longer is included. Types of communication that we can have for a G0071 are telephone call. Patient, hey, need to check in. Oh, yeah, you better come in for an encounter. Then you can't build a G0071. Oh, no, just, okay, you'll be okay. Just keep an eye on that. If anything changes, call us, but otherwise you should be fine. No further follow-ups necessary. Doesn't generate an encounter. G0071. Store and forward picture and video. So somebody's texting you something, I have to be sure that's HIPAA compliant. Remember, any of our store and forward technology has to be HIPAA compliant now. Remember, that was another waiver we got, is we could use non-compliant platforms for telehealth. G0071, I don't know how much it gets used, but I think it will start getting used more. There is co-insurance on both G2025 and G0071. You still have co-insurance. It's going to be the lesser of 20% of your charge or the payment amount. So basically, if you charge $100 for a virtual communication service, you're only going to get 80% of $23.71, and Medicare is not going to allow you to collect any of that. And you do need to have documented patient consent for both telehealth and G0071 to treat that patient via telehealth. You still have to have that consent in their chart. Don't forget about that. There's our claim example. Remember, hey, can we bill G2010 to Medicare? No. And conversely, our Medicare or our commercial plans are not going to recognize G0071. Transitional care management, this is one thing that came out at the beginning of last year. We can now bill transitional care management and care management services at the same time as one another. So a patient that we have on care management, we can bill a transitional care management service. So very important for you ACO people, folks participating in value-based care. Transitional care management is the golden ring. Don't forget about hospice and RHC rates after the Modernization Act. Hospice, we got last year. Hospice patients are now rural health clinic patients, effective January 1, 2022. hospice is an RHC location. So your physicians can now bill hospice patients, nurse practitioners, as a rural health clinic encounter. We have to have a GV modifier, George Victor modifier, along with our CG modifier to indicate hospice. We should no longer have to deal with the occurrence codes, value codes, whatever, to report non-hospice related. Just wouldn't put that service on the claim. Remember, we've had our Modernization Act. We're being considerably underpaid in Illinois. Considerably underpaid in Illinois. HFS rates have not kept up with Medicare. We are talking all the time about this, and we just had a call this week. How do we get HFS, Medicaid MCOs, to pay us our Medicare rate? And the answer is it's really difficult. But guess who gets their whole rate from HFS? You got it, FQHCs. So there's no reason we should be left out of this. It's time to start hammering the table with our shoe to say this is unacceptable. You guys talk about supporting rural all the time, but we can't get our rates. What's your problem? The Medicare rates will continue to go up. 2024 is going to be $139 will be the cap. The difference in a PPS, prospective payment system, and an encounter rate is that you have to file a cost report every year to get it. So every year, you've got to maintain your $126, next year $139. You got to file a cost report every year to get that. With a PPS rate, it would be set and we would forget it. That's kind of what's happening in Illinois, but it's set at $92 for some people or $94. And you're really lucky, maybe $104, but that's still an underpayment and an enormous problem in my view. All of my rural health clinics that sweat so hard overnight would be in the black if we got HFS payments at the Medicare rate and Medicare Advantage payment parity with our encounter rate, so that Medicare Advantage plans were forced to pay us our rate. Overnight, we'd solve many problems, not all problems, but we'd solve a lot of problems. So just keep in mind, you do have the opportunity to keep increasing your rate through 2028. That grandfather rate still exists, is based on your 2020 cost report if you're associated with small rural hospital. And I wanted to take a minute, and boy, I had to check this 50 times and make sure that this was nicely scrubbed. And we have this RHC claim payment problem. The RHC claim payment problem is that in effect, max, and this hasn't been for everybody, we think it's been for independent rural health clinics, and it largely started at the end of May, where max, we see here in column 5, started basically eliminating the 20% coinsurance from the Medicare payment, which has created a significant underpayment for anybody experiencing this problem. It's getting increasing attention. It's about to get fixed. I hope Nathan's not going to get mad at me because I'm not supposed to announce an adjustment yet. I have a typo in there, pardon me. But NRHC and CMS are about to announce a fix. We think we'll get a mass adjustment to fix our already paid claims and then take this logic out of the system and prevent the issue from continuing to happen. So you will be seeing an announcement for a fix on this. I know that's being talked about right now as we speak. That fix is on the way. That Social Security Act basic requirements right there on this link. It's helpful to go look at if anyone cares. That's where our primary care definitions are. CMS resources. One thing, oh boy, I don't want to fumble around to a website, but everyone needs to be aware of the RHC Burden Reduction Act. RHC Burden Reduction Act. It's hopefully eliminating some of our lab requirements. It is, I can't remember what all it's doing. I've got to look some of that up. The big thing is it's addressing our 51% problem, behavioral health to primary care, if we're in a mental health HIPSA. So I would encourage you, even though I don't have a slide, please go look up an RHC's information on the RHC Burden Reduction Act. And if you really want the gold star, get in touch with your legislator, preferably your US rep or Durbin or Duckworth's office. Contact your legislators and tell them why you need the RHC Burden Reduction Act and why you need Medicare payment parity for Medicare Advantage. I'm going to be there next week in person and bring the same message. RHC Burden Reduction Act, it's been announced in the House and the Senate. I look forward to seeing you at the beautiful University of Illinois Research Park in Champaign-Urbana, where I courted my wife, brings back fond memories, and boy, they got some great Asian food up there. Can't wait to get some ramen. So I look forward to seeing everyone. I see we've got a couple of questions in the chat. And can a provider, RHC, bill CCM while a patient is in home health, while a patient is in home health bill a care management service? I've never seen any prohibition on that. I'd have to look it up. I would look at the care management MLN, the care management, their Medler Matters or fact sheet. That's what I'm trying to say. Go look at that fact sheet. There's no prohibition on a patient that's in home health that I'm aware of, that I've ever seen. Let's see. Psychiatric mental health nurse practitioners are considered clinic and not classified as behavioral health. That makes a big difference. Pertaining to telehealth, that makes a big difference relative to your primary care to behavioral health, your specialty to behavioral health ratio as well. Let's see here. Oh, wow. Not able to work my questions here very well, so bear with me. I've missed one in here. Nurse practitioner Pierre, MD, works in psychiatry, performs a telemedicine visit for a medical purpose, i.e. medication management. Would this service be counted within the encounter rate or not? It totally depends on what CPT code that provider uses. So if I don't know that a nurse practitioner could use the 9073T code for medication reconciliation, for example, on a raw health clinic claim. I'm sure they could. I don't know what would stop that from being paid. Would it be counted within the encounter rate if it gets paid as if it gets billed as a 900 or a 521? Yes, it will be paid. Both of those will be paid at the encounter rate. How are mental health services being defined? Alex Weber gets the gold star for the question today. It's also a trick question because, to my knowledge, I don't have a definition. So what I always encourage people to do, clinics to do, is define primary care services versus behavioral health services for you. And here's what I mean. A nurse practitioner who sees a patient and reports an anxiety and depression diagnosis is not necessarily a behavioral health visit. What I would suggest is defining your mental health services exactly like you are suggesting. And I'm going to try to get down here a little bit. I keep losing the light by type or specialty or provider rendering the service. I would on your Medicare stuff, I'd define it by CPT code. If I report there's 7 behavioral health codes on the RHC qualifying visit list, 7. The RHC qualifying visit list is split up between medical services and behavioral health services. My suggestion is to write, it doesn't have to be a volume, it could be half a page. Our behavioral health services include services rendered by the LCSW for these 7 behavioral health codes listed on RHC QVL, period. And what do not constitute behavioral health services are any of our primary care providers who happen to see patients with anxiety and depression. So it's not by diagnosis, it's by CPT code. And I think it would behoove everyone, if you think you're on the threshold of that 51-49%, everyone really should have, if you have behavioral health services in your rural health clinic, define what are behavioral health services and what are not. Again, a nurse practitioner seeing a patient for nurse practitioner for depression and anxiety is not necessarily behavioral health service. If they're reporting a counseling code, then it would be. So that is a very important question, and it's really also going to depend on each clinic and your providers, what you are or aren't doing in that clinic.